Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in electrophysiology and cardiology will answer your questions about arrhythmias. Well, thank you so much for submitting your questions in advance. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you will see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but please note we may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. Sumit Banerjee with electrophysiology and cardiology, and Dr. Babak Bazorgnia, also with electrophysiology and cardiology. Thank you so much both for taking the time to join us this evening. First, I'm just going to give both of you a minute or two to say hello, provide some background information about yourself, and then we can go ahead and dive into the questions. So Dr. Banerjee, I will go ahead and start with you.
Great. Well, thank you. It's my pleasure to be here with you all this evening. Just in terms of a brief background about myself, I am an electrophysiologist by training. What that means is that I went to medical school and then I studied and trained in the field of cardiology and then chose to subspecialize in the field of electrophysiology, which deals with irregular heartbeats. And I've been practicing that field for just nearly 20 years. My main hospital is Jefferson Einstein Hospital, Philadelphia, where I practice electrophysiology and I also serve as the chair of cardiology.
Okay, well, welcome. We're happy to have you. Okay, and Dr. Bazorgnia, how are you doing this evening?
Good, good. Thank you for having me as well. I share the same subspecialty as Dr. Banerjee just mentioned. So we're both electrophysiologists. So we are the rhythm specialists. As you know, cardiology is now subspecialized into multiple. So we are the electricians. I'm one out of the 9 electrophysiologists that cover the Lehigh Valley area. That would be, Allentown, Bethlehem, Easton area.
Okay. All right. Well, thank you both for joining us this evening. I know we have a lot of questions to get to, so thank you all for submitting your questions in advance. So with that, let's dive in. Dr. Banerjee, you are the first one up here, so kicking us off for the evening. What causes the heart to develop arrhythmia after functioning normally for years?
Oh, it's a really good question. So, arrhythmias fall into different categories. So there's not just sort of one generic area. So you might hear terms like atrial fibrillation, atrial flutter, SVT. There's a whole host of them that exist, and they all have different causes. So there's certain arrhythmias that you're born with, and children may develop them at a young age. More commonly, I like to say that you're born destined to get them, which means that your heart's sort of predisposed to get them at some point, but it may not come about until your 20s or your 30s, or maybe even not until your 60s. And they're sort of predisposed to get them. And then there's a whole host of categories that occur because of whatever happens over the course of your life. So you may have a heart attack, unfortunately, and as a result of that and the damage that occurs from the heart attack, you may be suddenly set up to get an irregular heartbeat or a dangerous heartbeat that can cause problems. And then other situations where I like to say it's sort of like life taking its toll on your heart. All those coughs and colds and stress that you have over the course of your life sets you up to have the development of an arrhythmia. And that common area for that is something like atrial fibrillation. That's kind of the typical scenario in terms of categories of arrhythmias where you're sort of predisposed to get them at some point. SVT would be a common condition like that.
Okay. All right. Thank you. Well, you mentioned AFib, and this leads us into our next question here. Dr. Bazorgnia, what medications help control AFib, and would surgery be recommended as a potential solution?
Sure, I'm going to need about an hour to answer that one, but we'll
You have
try
three
to
minutes.
squeeze it in 2 minutes.
Yeah.
Um, So, as you mentioned, atrial fibrillation is the most common arrhythmia that we see, not just in this country, but around the world. Um, Atrial fibrillation can cause two problems. One, it can make the heart rate fast for no good reason. The other thing it can cause is a stroke. So, the first line of defense, as far as therapy, we use medications to control the heart rate, meaning not let it go fast. The common medications used are usually beta blockers or calcium channel blockers. These can be prescribed by a primary care to initiate or in the emergency room, depending on this status. The other problem AFib can cause is a stroke. So commonly, patients are started on an anticoagulant. These are blood thinners. Common medication would be Coumadin, or the newer ones like Eliquis or Xarelto that you might have heard of. So those are the first line of defense for medications. There are antiarrhythmic drugs, which is the next class of medications. These are stronger medications to help the patient, to help us keep the patient in normal rhythm. Those medications, because they're stronger, they have more side effects, they're more serious medications, and they're usually prescribed under the care of a cardiology, if not an electrophysiology. To answer the second part of your question, would surgery be recommended? Surgery is certainly one of our tools in our toolbox as our armamentarium to treat atrial fibrillation. Although the first line would be finding out why someone has atrial fibrillation and go from there.
Okay. All right. Thank you. Okay. Moving from medication to exercise. Dr. Managy, this question is for you. Is physical exercise safe for people who occasionally have rapid heart rates?
So another really good question. So I want to answer it a couple different ways. So we all have rapid heartbeats at some point, meaning that you may get excited, your heart rate goes up. Obviously, if you're exercising, your heart rate goes up. There are also individuals who tend to feel their heart rate go up more, meaning that they may feel fluctuations in their heart rate that are normal, but they're more attuned to those fluctuations. And it doesn't tell you that there is an arrhythmia or an irregular heartbeat. It's just that they have that sensitivity. But then, of course, there are the people who truly have an irregular heartbeat. So there are times when the heart may short circuit and starts to beat very rapidly. Now, again, in every situation is unique, and you do have to ask your physician and talk to your care provider a little bit more about your specific circumstance. But in general, exercise is safe in these situations. And the reason I say that is because most arrhythmias, most irregular heartbeats are not triggered by exercise. So it's in fact usually pretty uncommon that somebody can say, oh, this is the cause of my arrhythmia. I go and exercise, or I drink a glass of wine, or I am under stress and I suddenly go out of rhythm. It tends to be a more random event than that and less triggered. And so as a result of that, usually exercise is going to be safe to do in a situation where somebody has an arrhythmia underlying, or at least feels a fast heartbeat. But again, case by cases, there can be variation case by case, and you definitely should talk to your doctor about it.
All right. Thank you. Yeah, I was going to reiterate probably a conversation with your doctor, but thank you.
Yes.
Okay. Dr. Bezorgnia, we will go back to you here talking a little more about AFib. Is atrial fibrillation a genetic condition?
There is certainly a genetic component to it, meaning if your parents had atrial fibrillation, there's a higher chance that you would develop atrial fibrillation. But more importantly, atrial fibrillation is an arrhythmia of aging. So we see it in patients 65 on average. That's the peak age that we start seeing atrial fibrillation. There are also environmental effects that could make that age come earlier. So if you have a genetic predisposition, and on top of it, you have one of these risk factors, you could have atrial fibrillation earlier. What are those risk factors? The most common ones are obesity, which is unfortunately a problem that we have in this country. Other things, sleep apnea that sort of comes with obesity, but there are people who have sleep apnea even though they're not overweight. Alcohol is a common thing that could cause atrial fibrillation. So there's certainly a genetic component to it, but the environmental factors could exacerbate it when they're compounded together.
Okay. Thank you. Important to keep those risk factors in mind. All right. Dr. Managy, we will turn back to you here What are the long-term effects of taking medications for arrhythmia?
Yeah, good question. So there are many medications you may be prescribed to take the rest of your life and are perfectly safe. And so these are medications that fall into different categories, like beta blockers, for instance. Some common names, generic names are metoprolol, atenolol, propranolol. And these are just very common medications used for a variety of heart conditions. And you may be prescribed them for the rest of your life, and they are very safe to take for the rest of your life in nearly all cases. Uh, there are situations, though, there are other medications like antiarrhythmic medications or a whole other class that exist. And these are medicines like amiodarone, flecainide, sotalol, Ticacin. These are just some less common names that you may not be familiar with, that you may be prescribed, that don't necessarily get worse in your body over time, but may become less effective and could cause side effects, particularly as your heart begins to change over the course of your life. And that's why regular monitoring and evaluation are very important if you're going to be on medications long term. Again, as Dr. Bezorgnia talked a little bit about, there are a whole wealth of additional procedures now available that often take medications off the table as a need. But if you are prescribed medications, I'd say the vast majority of time they can be safe long term.
Okay, great. Good to know there's options available. All right, before we move on to our next question, just a quick reminder. If you have any questions that are popping up for you during our discussion, feel free to drop them in the Q&A and we will get to live questions in just a bit. But for now, we'll continue through our submitted questions. So Dr. Bezorgnia, we'll turn back to you here. What is the likelihood of arrhythmia returning after a successful ablation?
So we have to break that down a little bit. So it depends on what type of arrhythmia we're talking about. As Dr. Meneghy at the beginning mentioned, there are a few types of arrhythmias. For example, SVTs or supraventricular tachycardia, which tend to be arrhythmias of young adults. Because we understand the mechanism of them, the ablation of them are very successful, considered cured. 98% plus cured. However, there are other arrhythmias, like, for example, atrial fibrillation that we talked about briefly. The ablation for that is not as successful. So if you look at the most of the trials, the success rate of an AFib ablation is somewhere around 70-75%. And how we define success is not to cure atrial fibrillation, but to lower the burden of atrial fibrillation. Meaning if you're in AFib all the time, an ablation could make that you would have AFib every once in a while. So it's not cured, but it's much more manageable. There are some patients that will require more than one ablation in atrial fibrillation, so a second ablation perhaps, and that increases the success rate of the primary ablation. There are other ablation for more serious arrhythmias like ventricular tachycardia. Again, the success rate of that depends on how bad their cardiac structure is.
Okay. All right. And you answered my next question here, Dr. Manage, if you have anything else you want to add here, but I know you mentioned that cardiac ablations do sometimes have to be repeated. But yeah, welcome any additional thoughts there.
Yeah, I think Dr. Bezorgnia touched on a lot of those components. I think that the only thing I would add is, and this is really focused around the area of atrial fibrillation, because for SVTs and atrial flutter and some of the other kinds of problems, we really expect one ablation, and the vast majority of time the person's cured of the problem. But atrial fibrillation is another animal. And I often talk to patients and say it really depends. Your success rate for getting rid of this problem long term really depends what you bring to the table. How long have you had the problem for? How has your heart changed because of it? Do you have other conditions that may be contributing, like diabetes or high blood pressure or sleep apnea and things like that, that could have an impact of this? And those types of factor, and frankly, how early in the process have you decided to do an ablation? All of those things have a role in determining long-term success. And so there is certainly something that we'll talk about in each case. Well, I want you to be prepared. You may need a second ablation 6 months, 12 months, a couple of years down the road, perhaps. In addition, the only other thing I'll say is that we're often doing these procedures at younger and younger ages, as unfortunately patients are presenting at an earlier age with these types of problems. And because it's, as Dr. Bezorgnia said, it's often a disease of older individuals. If you're suddenly treating this in somebody who's 40 years old, well, they suddenly have a much longer timeline where they could really develop a recurrence in the future, and that certainly has to be taken into account as well.
Yeah. Interesting point there. Okay. All right. Thank you. Well, Dr. Managy, I might actually go back to you here for our next question. Let's talk a little about bradycardia. Can you tell me about what it is and how is it treated?
Yeah, so we've been talking about arrhythmias and been really focused on fast heartbeats. So the idea that the heart develops a short circuit, simplistically speaking, as we're electricians of the heart, so that's how we kind of talk about it, and the heart beats really rapidly. But the electrical system of the heart can also break down the other way, where it stops beating in a normal speed and actually slows down. And it may be something that you don't notice. Many people have a slow heart rate, and that's okay. It's acceptable. But you may be in a situation where you begin to feel lightheaded or dizzy or even pass out or just tired. And as a result, and it's as a result of a slow heart rate. And that heart rate is too slow for your body's needs. And that's what bradycardia is. Now, the textbook definition of bradycardia is a heart rate at rest that's less than 60 beats a minute. But again, I never treat the number, you treat the patient. And so it may be somebody who has a normal heart rate at 50, they've had it for their entire life, they feel absolutely fine. You don't need to react to that. But there could be another individual who has a heart rate of 50 and they feel like they're dizzy all the time, and we need to respond to that. And that could necessitate a treatment like a pacemaker.
Okay. All right. Thank you.
Mhm.
Okay, Dr. Bezorgnia, we will turn back to you here. Is there a definitive test to show where premature ventricular contractions, also known as PVCs or AFib, originate in the heart?
Um, yes. So the most common test that we do usually is just a EKG or electrocardiogram. You might have had it when you go to your cardiologist. It's a simple test that we do that, first of all, shows us what your rhythm is, um, whether you have atrial fibrillation or not. So, atrial fibrillation, usually we know where it lives. Usually it lives in the top left chamber of the heart. So that is not so much where it's coming from. We already know where it's coming from. The question is whether you're in it or not.
Mm.
Whereas premature ventricular contraction, which are basically few cells in the lower chamber of the heart that throw an extra heartbeat, that the EKG can really help us localize it. It doesn't localize it to pinpoint it, but it can at least give us an idea of what area is coming from. So if the ablation becomes the treatment strategy, we already have narrowed it down to the area of focus. So when we go in there, we can focus on that area to treat it from ablation standpoint.
Okay. All right. Thank you. Okay, Dr. Managy, we will turn back to you. Does long standing AFib increase the risk of heart failure? This person says, even if my heart rate seems controlled.
Yeah, it's a really good question, and certainly shows some really good understanding of what's happening with this person's body. So I applaud you for that. Uh, so what is heart failure? Heart failure is a situation where where your heart can't keep up with the needs of the body, simplistically. Like, so if you go to exercise, you may become more short of breath than you normally would. You might notice swelling in your legs or fluid in your lungs as a result of the heart's inability to keep up with the demands of the body at that time. And so, how could atrial fibrillation play a role in this? It can play a role a few different ways. So, certainly, if the atrial fibrillation is uncontrolled, so not exactly what the question was in this situation, but suppose the heart rate's beating really fast, well, then the heart may not have enough time to fill with blood. It just can't. It's beating so fast and chaotically and irregularly. It just doesn't have the normal function and time to react to the needs of the body, and you can develop heart failure in that situation. It also, just the rapid heart rate can tire out the heart, and the heart can begin to weaken. Now, sometimes that's temporary, and as soon as you get the atrial fibrillation under control, it goes back to normal. But sometimes that damage can become permanent, and you end up in a situation where the heart is actually pretty weak because of the grows weak because of the rapid heartbeats. But this patient's question was really about, well, what if it's controlled? So what if I just am left in atrial fibrillation, but my heart rate is controlled with medications and doesn't get too fast? Am I still at risk? And the short answer is you are. Not as great. The risk is much less. But unfortunately, just the irregularity of the heart, even if it's controlled, can cause the heart, particularly the left upper chamber of the heart, to begin to enlarge. And that can, over time, lead to leaking of heart valves and also the development of heart failure. So it doesn't mean it's going to definitely happen. And keeping the heart rate controlled is actually a very reasonable strategy for patients who have atrial fibrillation. But you do need to have good, careful follow up and monitoring. And it's not unusual to get something called an echocardiogram or ultrasound of your heart pretty regularly, like on a yearly basis when you're in that situation.
Okay. All right. Thank you. That's very helpful. Appreciate you breaking that down for us.
Mhm.
All right. We just have a few more submitted questions here that we're going to go through, and then we'll turn to our live questions. So thank you all for submitting those. I see them coming through the Q&A, so we appreciate it. For now, Dr. Bezorgnia, I will turn back to you. This question here, does the vagus nerve trigger AFib? How is that determined and treated?
So the heart does accept or get nerve endings from our nervous system. So yes, there are patients that report that when they eat a large meal or they drink a cold water or a spicy food, it triggers their atrial fibrillation. Um, but anything that increases the catecholamine in the body can set off atrial fibrillation. For example, a surgery, we often see patients who post-operatively end up having atrial fibrillation, or an infection can cause atrial fibrillation. So it depends what the underlying cause is when it comes to treatment. So if it's increase of catecholamine, surgery, or infection, the treatment would be to treat the underlying cause. Sometimes it's difficult to ascertain what's causing it. So, if you drink cold water and causes atrial fibrillation, you can tell them don't drink cold water, but that's sometimes not easy to do. But all those can be determined by, your cardiologist, your electrophysiologist when you see them.
Okay. All right. For this next question here, Dr. Manegy, no, we talked earlier about ablations for AFib. This question here says, if you've had AFib for many years, is ablation still a valid option if you are over the age of 60?
Yeah, so certainly the age doesn't make a difference, and we actually will take care of atrial fibrillation or treat atrial fibrillation with ablation well past the age of 60. As Dr. Bezorgnia said, the peak time of occurrence of atrial fibrillation is usually around the mid 60s. So that's right smack in the middle of where we would expect to treat it. So the age is not important. Absolutely, we would treat you at above the age of 60. But I think the real meat of the question is if you've had it for a long time, is it still worth taking a shot at trying to do the ablation? As I mentioned before, the success rate does go down the longer you've had atrial fibrillation. Treating it earlier in your disease process usually amounts to a greater level of success for long-term success of controlling the problem. But that said, there are other factors as well. And so one of the things that we would pay attention to is, again, other potential illnesses that you may have, like hypertension, diabetes, sleep apnea, other types of valvular heart disease, or have you had a heart attack before? Those things play a role, and we do want to know a little bit more about that. We also want to look at the heart. We want to do this echocardiogram, this ultrasound I've mentioned, to take a look at what the heart looks like, because that's going to play a role as well. If we see a heart that's very weak or enlarged, that may play a role in the decision as well in terms of giving you the odds. One of the things that I talk to patients about is to present the options, but also give them some realistic assessment of the success rate as well. And that, because it's not the same from person to person. The only other thing I would mention in this discussion that's of relevance is how the procedure has changed. So Dr. Bezorgny and I have both been doing this a long time. Excuse me. And we both remember a time where AFib ablations took hours. I mean, I'm talking 10 hours, 12 hours. I mean, these were very long procedures. Now, because of advancements in technology, and particularly a newer technology that came out a few years ago called pulse field ablation, what we've noticed is these procedures can be as short as 30 to 40 minutes. It's miraculous how these have changed. And with that shorter time comes improvements in safety. So that begins to change a little bit about the paradigm as to when you might consider doing an ablation if it's a less sort of onerous procedure. So a lot of things go into the discussion. It is certainly not something I would just give up on because you've been in atrial fibrillation a long time. I think it's worth having that conversation. And maybe it's not for you, but maybe it is.
Okay. All right.
May I add to that a little bit? I think what Dr. Maggie mentioned is, um, you know, persistent of atrial fibrillation. The more AFib you have, the more difficult it is to treat the atrial fibrillation. So the earlier we catch it, the better result we get. Just like anything else in medicine, the earlier we treat, the easier it is to get the success. So early access or early treatment is key here.
Okay. So that proactive care, got it. Good to know. Thank you. Yeah, and interesting to hear the advancements over the years. So really cool. Okay, thank you. All right, Dr. Vazornia, question for you here. Are there ways to prevent and stop a supraventricular tachycardia or SVT episode?
Yes. So prevention is more difficult, mainly because SVT, which again stands for supraventricular tachycardia, usually is a short circuit in the heart. So there's a short circuit in there. Right beat comes at the right time, and it's off and running. So it's more difficult to prevent it. However, there are ways to stop or disrupt the arrhythmia. These are usually happens in the young people. You might have heard of maneuvers like vagal maneuvers, bearing down. Blowing in a bag. Basically, you want to increase your intrathoracic pressure. One of the things that works really well, but it sounds weird, is if you have a bucket of ice water and you just dunk your face in it. I know it sounds weird, but what you're doing is you're trying to stimulate your sympathetic system to disrupt the AV node just for a split second, and it disrupts. It doesn't work all the time, I have to admit. But if you go to an emergency room, somebody with an SVT, those are the first maneuvers they start to see if it can stop the tachycardia. If that doesn't work, then they start with medications.
Okay, interesting. All right. Well, thank you here. Last question before we turn to our live questions for the evening. Dr. Managy, this one's for you. How does high blood pressure contribute to developing or worsening arrhythmias?
Yeah, really good questions. I've hinted about this a little bit as we've talked over the course of this evening about diabetes and hypertension and things like that. We often say hypertension is the silent killer because it just that presence of uncontrolled elevated blood pressure can take its toll on your whole body. And so we talk about hardening of the arteries because the body's facing this constant pressure. But from the heart standpoint, you can develop stiffness of the heart. And actually, if you were to magically look at every heart cell under a microscope, you would begin to see scar tissue and damage that occurs as a result of high blood pressure. And so specifically when we talk about the electrical system of the heart and arrhythmias, hypertension or high blood pressure can really lead to development of atrial fibrillation. It's a big risk factor for the development of atrial fibrillation. And so it really behooves us to make sure blood pressure is controlled as much as possible.
Okay. All right. Well, with that, I want to go ahead and turn to the live questions that we have coming in. And how we will do this, I'm going to go ahead and just ask the question. Whoever wants to chime in, feel free. This is definitely meant to be an open discussion. So, you both can chime in for any question that you would like. So with that, I will ask the first question here. Is there an association between sleep apnea and AFib?
Yeah, I think I alluded to that in one of the risk factors for environmental risk factors that could cause atrial fibrillation. So the answer is absolutely yes. As a matter of fact, when we discover atrial fibrillation, one of the first tests that we order, besides the tests that Dr. Managi mentioned, like echocardiogram, EKG, would be a sleep study to see whether or not patients have sleep apnea. And treatment of sleep apnea have shown that it will improve atrial fibrillation long term, not only just frequency of it, but long term success of the treatment, even after ablations and sophisticated things like that. So yes.
Thank you. All right, next question here. Okay, and feel free, to chime in. This one's a little bit more of a personal question, but we'll see your thoughts. This person says, I have a personal portable EKG device. It tells me I have a sinus rhythm with supraventricular ectopy. What does that mean, and is it concerning?
Sure. So, one of the it's actually been wonderful for our field that patients now have access to these consumer devices. So things like an Apple Watch or Garmin has products, and I think Samsung has products. And there's a whole host of these things. One of the ones that you might see on television is something called the Cardia by AliveCor. It's a little plate that you put your fingers on, but and the Aura Ring. So there's a whole host of these products that now allow you to monitor your EKG. And they actually are pretty good. They're almost all now approved by the Food and Drug Administration as being valid technology. But one of the things you have to be careful about uh, is reading too much into it. And I say this because you can get what we call a false positive, which is that you may be told that you have an atrial fibrillation by the device, and you may not. It works really well and has been well studied and validated in an appropriate population. So if you're in your 60s and you get a diagnosis of atrial fibrillation from your Apple Watch, it probably is more likely to be accurate than if you have a 22-year-old who gets a diagnosis of atrial fibrillation. And in fact, it was just that their heart was going really fast while they were exercising and it misinterpreted it. So, with that background, what does it mean to have sinus rhythm with these ectopic beats? What that's telling you is that it's detecting an occasional extra heartbeat coming from the top of the heart. So, you can get extra heartbeats from the top, you can get extra heartbeats from the bottom of the heart, which are called PVCs. They're called premature atrial contractions in the top of the heart. And we all get them. They're absolutely normal. So the only reason to be concerned and to do anything about it is if it makes you feel uncomfortable. You notice your heart having skipped beats or what we call palpitations. You feel uncomfortable. Then it may be worth to explore it a little bit more and maybe to do a more formal monitor, something called a Holter monitor that your doctor could prescribe for you.
Okay. All right. And Dr. Bezorgnia, anything to add there?
Yeah, so I would add to while these wearables are a blessing, we do caution that we don't want them to make you anxious. They are nice, especially if you have a family history of arrhythmia, or you actually have been diagnosed with arrhythmia, you've had an ablation that you want to follow to make sure the ablation is effective, but don't let it make you anxious. Be careful. It's a double-edged sword.
Yeah, absolutely. Important call outs. Thank you. Okay. Question here about ablations. This person says, after ablation surgery, how long is it typically recommended to use blood thinners?
So, good question, but a complicated question. It really depends on the risk factors and what type of arrhythmia we ablated. So, if we're talking about the most common one, which is atrial fibrillation, and that's the arrhythmia that most people are anticoagulated for. Because the atrial fibrillation ablation, as I mentioned, is not considered a curative procedure, meaning you could still have AFib, perhaps not as much. Um, Treatment risk factor high, and there's a scoring system that we go by. You might have heard Chad's vast scoring system, which is basically the acronyms for your age, whether or not you have some of these risk factors like high blood pressure, diabetes, history of stroke in the past, history of heart failure in the past. And the higher the score is, the higher the risk of stroke. So if you're someone who has a very high score, even if your ablation has been successful, we're less likely to take you off the blood thinners. Why? Because the worst thing this arrhythmia can cause is a stroke, and we're very aggressive in treating that. However, if your risks are low, you're a younger person with no other risk factors like diabetes, high blood pressure, heart failure, with a discussion with your physician, you may be able to come off of it. Usually, though, anyone is at least 6 weeks to a few months treated post ablation just to make sure the ablation actually worked.
And the only thing I would add to that is it's important to have a discussion with your doctor before the ablation to sort of set expectations. What are your goals for having the ablation done? Is it to feel better, which is a great reason to do it? Is it because you're worried about your heart weakening? Also, great reason to do it. Or is it because you want to simplify your medical regimen and maybe come off some of these medications? Because I think it's important to go into it with realistic expectations of what may happen after it's done.
Okay. All right. Thank you both. Okay, next question here. And thank you all for submitting such great questions. We have a lot coming in. This next one here. What is an inverted T wave and is it dangerous?
Dr.
Yeah, so
Meneghy,
neither of
go
us,
ahead.
yeah, neither of us want to answer that question because
I see your hesitation.
it's a complicated question. Yes, it's a complicated question. It's the kind of question that would make medical students like shake a little bit on rounds. So it inverted T waves. So what are we talking about? We're talking about the EKG. And so when you go to your doctor's office or to the hospital and they hook you up to all the electrodes, as Dr. Bazorgnia mentioned before, we get a little tracing with all the squiggles on it. And one of the squiggles on that is something called the T wave. And it refers to a very specific part of the heart's contraction and what's happening during that time. And sometimes that T wave can be inverted, meaning it should be upright. It actually turns upside down. And it may occur in a situation where nothing is happening. You go into your doctor's office for a routine visit, you feel absolutely fine. You just happen to go in and get an EKG. You discover this, and there's probably not much meaning behind it. Maybe some additional tests like the ultrasound of your heart or even a stress test may be ordered, but there's probably not a lot that may come of it. Flip that over to a situation where you enter to the hospital and you're having chest discomfort, or you've had a stroke, or something else is happening, or you've recently had a very rapid heartbeat, then we may discover an inverted T wave on that. And that may be more a sign that something is evolving. Again, like a heart attack or a stroke is happening, things like that. And we have to get to the bottom of it. And that's why it's a tough question to answer.
Understood. But appreciate you walking us through that. Anything to add, Dr. Bazorgnia?
Yeah, so to elaborate on that is, by what we mean is by itself is kind of meaningless. With other stuff, then it starts having meaning. So again, I would encourage not to overread like your own EKGs. I saw it flip T waves. What's wrong? Ask your physician to interpret that for you.
Right. Yep. A reminder to talk to your doctor. So, all right. Thank you. Next question here, which I know we've covered risk factors, but I do think it's an important one. So I will ask it. Are there any steps someone should take to minimize arrhythmia, diet changes, behavior, or habits?
Absolutely. So again, if we're talking about the most common arrhythmia, so SVTs, you're born with it. There's not much you can do with it. Thankfully, they're curable. Atrial fibrillation, which is the most common arrhythmia we see, is heavily influenced by what we do, as I mentioned. So, healthy diet and exercise, meaning having a healthy weight, helps tremendously. There was a study out of Australia that showed even modest amount of weight loss. We're talking about 6 to 10% weight loss would have an 80% improvement in the occurrence of atrial fibrillation. It's hard to find a medicine that works so well. So diet and exercise and weight loss, or having a healthy life balance, works wonderfully. Alcohol is a known initiator of atrial fibrillation, especially binge type drinking. And we're not talking about, a glass of wine or a beer, but sort of binge type drinking over the weekend. There is a concept called the holiday heart, where people drink over the weekend, and then uh, initially during the week, as the alcohol washes out, is when the atrial fibrillation kicks in. So those are the most common environmental things. Patients ask, "What can I do to help my atrial fibrillation?" These are the things you could do.
Okay.
Yeah, the only thing I would add to that, I think, because Dr. Bazorgnia, I think was good and detailed in his answer, was the moderation. And the binge drinking is really important to avoid. And the same thing with excessive amounts of caffeine. Now, that said, I will tell you, and Dr. Bezorian, please chime in if you disagree. Um, but one of the things that often bothers me is a patient who may come in and they've been told by a doctor that avoid all caffeine, all alcohol, all chocolate, like all of these very substantial restrictions, because that could set you into an arrhythmia and atrial fibrillation. Now, there are occasional situations where a patient will have a single glass of wine, for instance, or a beer, and will go into atrial fibrillation. But those are unusual patients in my experience. It's more the patient who's drinking a much more excessive amount. And so I really um, try to avoid absolutes for our patients. Like it's not, don't, don't have don't have any coffee. I don't think it's a reasonable thing. Have your morning coffee if it brings you joy and wakes you up in the morning. Have a glass of wine. Again, moderation is really important. I don't think we should live in absolutes with regards to arrhythmias and diet.
100%. Yes. A cup of coffee is fine. A pot of coffee, not fine.
Mhm.
Same
Yes.
thing with a glass of wine and a whole bottle of wine.
Now, the only thing I will say is I'm not a big fan of these caffeinated drinks, or like the what's it, like a Red Bull was kind of the old my
Energy
generation's
drinks.
like thing with the energy drinks, yeah. But now, like the stuff that I see my daughters drinking, it's like Celsius and these other brands, and I don't want to throw any particular brand under the bus, but I just get a little nervous because they have these very high amounts of caffeine in them, and perhaps some other things as well that may not be good to drink.
If you have AFib, definitely stay away from those.
Okay, noted. But I think overall it's good news to hear, moderation versus absolutes. So thank you. Okay, next question here. Dr. Manaji, maybe I will turn this one to you just because I know we talked exercise at the beginning. This person says, how safe is it to return to strenuous exercise like a triathlon after a successful intervention for AFib? How long after?
Yeah, so it's a really good question. So the certainly immediately after a procedure, I'd ask patients to avoid any strenuous activity or heavy lifting for a week or two. Now, again, that's open to a little bit of interpretation. So if you're asking the question because you're into sort of more substantive exercise, in 2 weeks may be the appropriate time. And then that's really to allow your legs to heal after the procedure. A typical ablation is performed through catheters put in through a vein in the leg at the groin area. And so that's where we get a little bit worried with the access that you could have bleeding if you exercise too quickly. Now, beyond that, the question is as well, am I going to put my heart under too much strain and stress if I do it too soon? And there's not a perfect answer here. I would say that I'm very comfortable with somebody returning to the gym and doing sort of weekend warrior type of activity early after an ablation within a few weeks. And that would be like, oh, I want to go out for a jog on the weekend or so on. But if you're talking about major endurance exercise like a marathon, a triathlon, Ironmans, those types of things, then I really think you should probably wait a couple of months to make sure that you're through the worst of the healing process, which typically is on the order of 6 to 12 weeks. Make sure the heart's back to normal, you haven't had any recurrences, and then go from there.
Okay. All right, thank you. Okay, next question here. This is actually a helpful question that kind of grounds us a bit. This person says, can the doctors explain what ablation is and what it means?
Sure. Go back to the basics. So
Yeah.
ablation is basically a focal destruction of the pathologic tissue. So all we're doing is imagine a tip with the tip of a catheter, which is not larger than a tip of this pen. We enter the heart and we target the tissue that electrical tissue of the heart that's causing a problem. So it's actually ablating or burning or destroying that tissue, but it's very targeted. Like I said, it's as big as a tip of this pen. Um, there are many types of energy sources, so we can use heat to destroy that tissue. We could use cold or cryo, or the latest and the greatest one that Dr. Manigi mentioned is the pulse field ablation, which does it with just electroporation or electricity. So ablation is a fancy term of we're destroying tissue that causes the problem.
All right. Thank you. Okay, next question here, a little more specific. This person is wondering, is there a target ejection fraction for patients with arrhythmia that can be identified with an echocardiogram? What's considered high or normal?
Yeah, so normal ejection fraction is usually 55% or more. Now, what is the ejection fraction? The ejection fraction is the amount of blood that gets pushed out of the heart with every heartbeat. So with every heartbeat, the expectation is 55% or more of the blood should get pushed out. If it's lower than that, and obviously the lower you go, the more away from 55% you go, the worse the heart is technically beating. That's when you begin to have things like heart failure, where the heart may not be keeping up with the needs of the body because it's not squeezing enough. And that is something where if you have atrial fibrillation and you have a weakened heart, we can sometimes see improvements in the ejection fraction if the atrial fibrillation is well controlled.
Okay. All right. Thank you. Next question here, Dr. Bazornia. I'll actually turn this to you as it's a follow up about ablation. This person says, can they specifically explain what pulse field ablation is?
Yes. So as I mentioned, so pulse field is the latest iteration of ablation technology. Uh, it does the same thing as I mentioned, is destroys the targeted tissue, but it does so with electroporation. So we use high voltage electricity to make holes in the cells, the targeted cell. And once you put enough holes in the cell, it makes it irreversibly destroyed. The advantage of electroporation is that it gives us it is myocyte specific, meaning we can target only the tissues in the heart that we intend to do without affecting other tissue around. Remember, your heart is surrounded by your lungs, by nervous systems, by your esophagus. If we use heat or cold, remember thermal energy does not differentiate between your esophagus, your nerve, your lungs that are there, if you use heat or cold. Where electroporation, we can dial it up and down so that at this voltage, it will only ablate the heart tissue. So it's specific. So it's we can put it on top of the esophagus and nothing happens to the esophagus, and hence it's safer.
All right.
And to just put a little bit more to that, so we've been doing ablations for atrial fibrillation for over 25 years. It's been around for a long time. Radio frequency energy, which is sort of a heating of the tissue, has been around since that time. And about in 2010, 2011, sometime in that time frame, freeze technology became the standard, became another very acceptable standard for AFib ablation as well. And until about 2 years ago, they almost had an equal split in the United States as to how comparative technology. So maybe 50-50, 50% of patients were getting one, 50% of patients were getting the other. Pulse field ablation came out 2 years ago, and as Dr. Bezorgnia said, proved to be safer, and also, as I mentioned earlier, proved to be more efficient. Really helping drop the time of the procedure down considerably. And so those two characteristics have made it sort of the dominant technology used today across the country. I'd say certainly 75% probably of ablations now in the US for AFib are done that way, but and it'll probably be much higher very soon.
All right. Thank you. Good question. Okay, just a few more questions here, and then we will wrap up for the evening. I have one final question for myself. But here we'll get to two more questions. This one says, do hormonal changes in women play any role in arrhythmias?
Um, I'm not sure. There's no known direct link with that. Uh, that being said, it gets complicated because, as I said, AFib is an arrhythmia of aging. So as you age, it does become more frequent. No, there's no direct link between menopausal stages that will cause atrial fibrillation. It's more the process of aging.
Okay. All right. Next question here. What is premature atrial complex? Does it lead to other rhythm problems over time?
Yes, we did talk about that just briefly before. So Premature atrial complexes or premature atrial contractions often are abbreviated as PACs or ectopic beats. And so that was the question earlier with the Apple Watch that demonstrated sinus rhythm with these ectopic premature beats. And what that means is that the top of the heart is throwing in some extra beats here and there, not enough to launch it into an SVT or atrial fibrillation, but just these extra beats, which we all get. Uh, Generally, again, not something to worry about and not something to do anything about unless it's making you feel uncomfortable, which means that you're feeling the palpitations. It's disrupting your day, and then it may be worthwhile to get a more substantive evaluation, like a Holter monitor from your doctor, an echocardiogram or ultrasound of your heart, and then maybe a medication to slow it down, but only if you're not feeling well. Treat the patient always. That's my key.
Okay. All right. Thank you for that recap. All right. And with that, we will wrap up for the evening. So I just have one final question this evening. And that is, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? Dr. Manaji, we will go ahead and start with you.
Yes, no, I think it's been a really great discussion. I mean, the questions were well thought out, so I'm very appreciative for all the time that everyone put forth to this, and I'm very happy to be here to participate. I think that the takeaway message is really that arrhythmias exist. When people typically think about heart disease, they think about blockages in the arteries, heart attacks, high cholesterol, going on a good diet to reduce the risk factors for that. And it's often not well known that the heart has an electrical system that can break down and it can cause beats to be too fast or too slow, as we've spent the last hour talking about. So what I would really encourage everyone to have is awareness. If you feel palpitations, the feeling of your heart racing or skipping beats, lightheadedness, dizziness, if you've ever passed out or pass out in the future frequently, uh, these are things that you should be worried about and you need to get evaluated. Don't be dismissive of them because they could represent a serious problem. I often relate that I've had many a patient, particularly it's often women, who have been diagnosed with panic attacks and anxiety over many years, and it turns out they actually have an SVT or an arrhythmia that could be treated, and it often cures the problem. So take these symptoms seriously.
All right. Thank you. Important advice. Okay. And Dr. Bazorgnia.
Yeah, I will echo those, and I'll go with early detection and early treatment. So just like anything else in medicine, the earlier we treat it, the easier it is. I'm sure Dr. Meneghe have seen patients that show up to see us after being in atrial fibrillation for many years. And unfortunately, as the heart is in atrial fibrillation, it develops scars. So our treatment options, the success rate dramatically drop. So we ask, a referral, or most importantly, at the patients, just like anything else that you have, you want to treat it early, treat the arrhythmia the same. There are electrophysiologists now available around the country. So, Philadelphia and the surrounding, there's no shortage of them. So try to be seen early because the treatments have grown tremendously. Ablation therapy is now considered standard of care. For SVTs, it's a curative. For AFib ablation, now there's class 1 indication. Before we used to, offer the patients antiarrhythmic medications, and only if they failed, we would go to ablation. Now, because the ablation has become so safe and efficient, we can offer it as a first-line treatment. So early detection, early treatment.
Okay, great. Thank you. Important advice. And to put it simply, when in doubt, go to your doctor. So thank you. All right. Well, thank you so much, Dr. Maneghe and Dr. Bazorgnia, for your time this evening. Such great information was shared. I know I learned a ton. And thank you to our audience for attending and submitting your questions. As the doctors mentioned, we really appreciate your participation and your willingness to be your own best self advocate. We will be posting an event survey so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health or Lehigh Valley region provider, please go ahead and fill out the last question in the event survey. A recording of this event will also be sent to you next week so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.
Thank you, guys.
Thank you.